retros retrospective, or have there been prospective studies run as well looking at lithium as being a better means to treat suicidality?
Yeah, so they have they do have prospective studies, but yeah, I mean the majority of the studies are retrospective and use large epidemiological cohorts, but they're so large that they're very convincing. They're both large and it's a repetitive finding. So like, yeah, sure, if you find it in one study, it's like, okay, it could be, whatever, but study after study shows it. And there are some prospective studies on it as well. Yeah, but of course not as much and not as many patients. The one that just came out, I can't remember honestly off the top of my head, the one that came out within the last month, if that was prospective or retrospective, I can't remember honestly.
Okay, so when you treat with, well, let me take a step back. Do you think about suicidal ideation as a symptom of the disorder, or do you view it, is it like a distinct diagnosis, or how is it assessed and documented?
I consider it a symptom of the disorder. I don't consider it a separate entity in and of itself. And, the reason being that if you get the bipolar depression under control, then the suicidal ideation seems to dissipate. So, I consider it kind of part and parcel. And, I document it as a symptom of that current depressive episode.
Okay, so when a patient presents then, is that your treatment goal or your primary treatment goal? Is it to get the bipolar depression under control rather than to explicitly try to treat that symptom itself? Or are they one and the same?
Well, that's a good way to put it. I would say that the goal, the number one goal in psychiatry always, I think, is to reduce a patient's risk to themselves and others. And so as far as that's concerned, I would say the number one goal is to eliminate the suicidal ideation. However, I don't think that one goes away without the other. It's unlikely the suicidal ideation is going to go away and no other symptoms of the bipolar depression would be going away with it. It kind of all, tends to go together. But yeah, ultimately the goal is to get rid of the suicidal ideation. Like, you don't want anyone being depressed, but it's okay, if someone is depressed, it's not necessarily an emergency. Depression can be reduced over time, et cetera, et cetera. But suicidal ideation, you really have to try to get rid of as quickly as possible because it's dangerous. And, bipolar disorder in psychiatry, is one of the highest, you probably heard, is one of the highest suicide rates compared to other disorders, much more than major depression. And
yeah, I had seen statistics on it, on there being, I think I had read that it accounts for almost a quarter of all suicides in the United States every year.
Yeah, it wouldn't, that wouldn't surprise me at all.
Okay. Yeah, I'm just trying to understand if, from a treatment algorithm standpoint, if, when a patient presents, if you're looking to identify, are they non-compliant to their maintenance therapy or, mood stabilizing therapy or antipsychotic or et cetera, and that's what's driving the ideation behavior, or do you, prioritize